Welcome to this unique educational activity focusing on novel strategies to address unmet needs and the burden of disease in moderate to severe alopecia areata. Alopecia areata is a chronic autoimmune disease characterized by non-scarring hair loss and is currently estimated to affect up to 6.8 million people in the US. Hair loss is often limited, with only one or a few patches involving the scalp, but any hair-bearing site, such as eyebrows, eyelashes, or beard in men, may be affected. It is not uncommon, however, for there to be significant or complete scalp hair loss in addition to body hair loss. The age of onset varies, and it may occur in any decade of life, though disease onset usually occurs in patients aged 40 years or younger. There is a wide clinical spectrum of alopecia areata. Patchy AA, which manifests as circular or ovoid patches of hair loss that may collide to form polycyclic patches, is most common. Other patterns of alopecia areata can also occur, such as the ophiasis pattern, in which patients experience a band-like area of alopecia extending from ear to ear across the occipital scalp. Sisypho pattern is a much less common pattern in which patients experience loss of hair on the top of the scalp, sparing the sides and the occiput. And then diffuse pattern, alopecia areata, is generalized thinning of the scalp hair. And again, I want to emphasize, typically scalp is involved, often with other sites of involvement, but it may be that the scalp is uninvolved, but that eyebrows, eyelashes, beard, or other body hair is lost. Exclamation point hairs are short, broken hairs for which the proximal end of the hair is narrower than the distal end, are a common and pathognomonic finding in alopecia areata. Exclamation point hairs are typically found at the edges of expanding patches and can be pulled out from the skin with minimal tension. Again, this can be used to help distinguish clinically alopecia areata from other forms of alopecia. Estimates of nail involvement vary widely, and it may be that it occurs more often in patients with severe hair loss. Nail disease may precede, follow, or coexist with active hair loss. And so don't dismiss the possibility of nail disease related to alopecia areata just because a patient is not missing hair. Pitting of the nail plate is most common. However, a variety of other disorders, including trachyonychia or roughening of the nail plate, onychorexis or longitudinal fissuring of the nail plate, onycholysis, separation of the distal nail plate from the nail bed, and onychomedisis, detachment of the proximal nail plate from the nail bed, may also be seen in patients with alopecia areata. Now, the disease course. About 50% of patients with limited patchy hair loss will recover within a year, with or without treatment, although most will experience a recurrence of disease subsequently, months or years or even decades later. This is an important point to emphasize because I think all too often patients are told, oh, you are only going to have that which you're coming in with today, a patch or a few patches, and I can assure you this is going to be the worst of the disease. But again, statistically, we know most patients will experience a recurrence of disease subsequently, whether it's months from now or decades from now. And patients want to know what to expect, and so I think it is of the utmost importance that we inform them of what frequently occurs in similar patients. Some patients do experience progressive disease and or persistent alopecia, and this is part of the reason why I bring up that last point. It's hard to know who is going to progress. And while some patients progress with severe disease from the start, many do not. And so we don't know at a moment in time who's who. More severe hair loss often persists for years or indefinitely and may be refractory to treatment. At least historically, we've always thought that severe hair loss was refractory to treatment. I think emerging treatments are going to change our perspective on that. The following factors have been associated with increased risk for a poor prognosis or high likelihood of relapse. Onset of disease in childhood, severe scalp hair loss, such as alopecia totalis or alopecia universalis, duration of alopecia areata for more than 1 year, meaning spots that persist in spite of treatment for a year or longer, ophiasis pattern, the presence of nail disease, and a family history of alopecia areata. So let's spend a moment talking about the comorbid diseases that are frequently seen in patients with alopecia areata. Comorbid autoimmune disease is one category, and we know that patients with alopecia areata frequently have autoimmune thyroid disease. And indeed, depending on what kind of thyroid disease we're thinking about, thyroid disease is more than twice as common in patients with alopecia areata as in the general population. Similarly, comorbid atopic disease is more common in patients with alopecia areata, and atopic dermatitis itself is more than twice as common, again, in patients with alopecia areata than in the general population. Similarly, we see asthma and allergic rhinitis more commonly in patients with alopecia areata. And lastly, comorbid psychiatric disease. The lifetime prevalence of depression and anxiety in patients with alopecia areata is high, and some numbers place it as high as 39%. So altogether, we see that across autoimmune and inflammatory diseases, patients with alopecia areata frequently have a greater burden of disease than other patients, and for sure, than the general population. And this is just the perspective through the lens of thyroid disease and atopy. If we look at all autoimmune disease, indeed, depending on the study, we see a greater likelihood of comorbid autoimmune diseases in patients with alopecia areata than in the general population. And so I really, personally, I think of alopecia areata as being a disease that we frequently see in polyautoimmunity. It's not just thyroid disease, but rather it's across a host of autoimmune conditions. Shown here are the results of a study in which 45 patients were interviewed. They were asked open-ended questions about their disease and the effect that the disease has on them. And what we see is that everybody starts with hair loss. So hair loss is kind of the epicenter of everything else that happens. We see that there are signs and symptoms of the disease. So again, itching, burning, tingling in areas of hair loss. And then as a result of losing eyebrows and or eyelashes, some patients will develop eye irritation. Some people will develop nasal irritation as a result of losing their nose hairs. Some people report sunburn as a result of losing all of the hair on their head. And then we have downstream effects such as social and lifestyle impacts, relationship impacts, and then psychological impacts. So we have a profound impact on patients as a result of hair loss. And so I like to think that somebody who's experiencing depression or anxiety, as a result of hair loss, we don't send them to a psychiatrist for treatment of their depression or their anxiety. Instead, we treat the hair loss. And by doing so, we make the depression and or the anxiety better or make it go away. We can have a significant impact on the whole person by treating the very thing at the root of all of the problems, the hair loss. So now let's jump into advancements in our understanding of alopecia areata pathogenesis. There's just been so much excitement in the last few years about alopecia areata and the idea that reliably effective therapies are on the way.
Hair follicles are immune-privileged sites with complex and intricate structures to maintain their immunity against the body's immune system. The key features of an immune-privileged site are low major histocompatibility complex class 1 and 2 expression and well-suppressed natural killer cells. In alopecia areata, CD8 positive NKG2D positive T cells form immune synapses with follicular epithelial cells and in turn upregulate MHC class 1 expression through JAK1 and JAK2. Concurrently, NKG2D ligands such as MHC1 related chain A and UL16 binding protein 3 are also upregulated through JAK1 and JAK3. Activated CD8 positive NKG2D positive T cells release interferon gamma that binds to its receptor on follicular epithelial cells, causing transition into catagen phase. This also causes follicular epithelial cells to promote the production of IL-15 through JAK1 and JAK2. IL-15 in turn binds to its receptor on CD8 positive T cells and induces JAK1 and JAK3 mediated interferon gamma production and ultimately completes the feedback loop. Since JAK-STAT dependent cytokines including interferon gamma and IL-15 drive proliferation and activation of autoreactive T cells in alopecia areata, it's important to understand the clinical relevance of the JAK-STAT pathway as well as the rationale for JAK inhibition as a novel treatment strategy. The mammalian JAK family consists of 4 members: JAK1, JAK2, JAK3, and tyrosine kinase 2, or TYK2, which selectively bind different receptor chains. Upon binding of ligand to its cognate cytokine receptor, associated JAKs become activated and undergo autophosphorylation and transphosphorylate the intracellular tail of their receptors. This creates docking sites for the SH2 domain of the cytoplasmic transcription factors termed signal transducers and activators of transcription, or STATs. Following phosphorylation, STATs dimerize, translocate to the nucleus, and bind to specific DNA sequences to regulate gene transcription. The JAK-STAT pathway is pivotal for the downstream signaling of inflammatory cytokines, including interleukins, interferons, and multiple growth factors.
And so we have an opportunity with a small molecule inhibitor, not a protein, but a small molecule inhibitor called a Janus kinase inhibitor or a JAK inhibitor to stop this race. I think of this as a relay race where the cytokine passes the baton to JAK, JAK passes the baton to STAT, STAT in turn passes the baton to the nucleus. If we can tie the hands of JAK so that the baton never makes it to the intracellular space, then we break the disease and the disease gets better. So let's look at the data for JAK inhibitors for the treatment of alopecia areata. So one of the really exciting developments, I think, is that there's so much data just from case reports and case series and open label clinical trials of JAK inhibitors in alopecia areata that it really is clear that these molecules are going to change the treatment landscape of moderate to severe disease. And the real testament to that is that in a recent JAD CME, in the treatment algorithm for alopecia areata, we see JAK inhibitors emerge. And this is really the first time that we saw, in a sense, kind of expert guidelines about the treatment of this disease, the introduction of JAK inhibitors, which again, I think is just, it's a real testament to the fact that those of us who do this really believe in it. There are a few FDA-approved JAK inhibitors, none in dermatology, and really important to call out, there is no FDA-approved JAK inhibitor for the treatment of alopecia areata. There are only investigational agents that are in clinical trials presently. But again, we do have a few JAK inhibitors, again, outside of dermatology presently, that have showed efficacy in case reports, case series, and open label clinical trials. Tofacitinib is one of them. It is presently FDA approved for rheumatoid arthritis, psoriatic arthritis, juvenile idiopathic arthritis, and also ruxolitinib, which is another JAK inhibitor approved for use in oncology and hematology, in particular polycythemia vera, myelofibrosis, and acute graft-versus-host disease. So let's look at data for investigational JAK inhibitors in alopecia areata. We're going to look at data for ruxolitinib 1.5% cream, ritlecitinib, which is a JAK3 TEC inhibitor, CTP-543, which is a JAK1/2 inhibitor, and baricitinib, another JAK1/2 inhibitor. Ritlecitinib, CTP-543, and baricitinib are all oral JAK inhibitors. Just as way of background, the primary endpoint in alopecia areata clinical trials measures scalp hair regrowth over the trial period. The severity of alopecia tool, or SALT score, is an assessment of the amount of scalp hair loss in a patient. A SALT score of 100 is the same as 100% scalp hair loss, and a SALT score of 0 is 0% scalp hair loss. And so we're going to be looking at changes from baseline over the duration of a clinical trial to understand efficacy. And so we're going to look at data such as SALT 75 or SALT 90, which is a 75 or 90% change from baseline SALT score. Or we're going to look at data also as the percentage of patients achieving a low SALT score, meaning near complete scalp hair regrowth over the duration of a trial. So let's start with the data for ruxolitinib 1.5% cream. Again, what everybody wants to think about is we want very high percent change in baseline SALT scores. So in this case, a SALT 90 is what we're looking for, 90% regrowth from baseline. And as we see in the data here, almost nobody in this clinical trial achieved that significant change in SALT score over the duration of this clinical trial. And so it seems that topical treatment, at least with ruxolitinib 1.5% cream, does not work in the treatment of severe alopecia areata. Just a quick call out, I also did an open label study of tofacitinib 2% ointment in 10 patients with severe alopecia areata, and there was only one responder. And so again, so far we don't really have provocative data to suggest that topical JAK inhibitors are effective for alopecia areata. So now let's look at the data for the oral agents. This is really exciting. We're going to look at three results from 3 different phase 2 clinical trials. There's the data for ritlecitinib. Now this was a trial that was done together with an agent brepocitinib, which is a JAK1 TYK2 inhibitor. The reason I'm really going to focus on ritlecitinib is that this is the agent that moved on into phase 3 clinical trials. What I want to point out here, again, what we're looking for are very high percent changes in baseline SALT score, so SALT 75 or SALT 90, and we see that a quarter of patients over 24 weeks of treatment with ritlecitinib are getting this dramatic change. Now looking at CTP-543 and the data for that compound, we see here 3 doses versus placebo, and we see at the 2 highest doses, 8 milligrams and 12 milligrams, we see a third or more of patients achieving a 75% change in baseline SALT score over 24 weeks of treatment. This is awesome. And now lastly, baricitinib. Here we have a 36-week trial with a slightly different endpoint. So in this clinical trial, we're going to look at the proportion of patients achieving an absolute SALT score less than or equal to 20. So less than or 20% scalp hair loss after 36 weeks of treatment. It actually turns out to be very similar to a SALT 75 in the other clinical trials. What we see is a third to a half of patients achieving this dramatic scalp hair regrowth over 36 weeks of treatment. And so we have the outcomes of 3 trials with 3 different JAK inhibitors showing great efficacy, what I would call reliably effective treatment. Treatment such that you can tell a patient at a visit, you know, in the future, coming soon, are medicines that when you take them, I can tell you that there's a very good chance that you're going to regrow your hair. This is what all of us want. This is what our patients want. This is going to change the way we think about this awful disease. I really believe that with these results, we're going to move beyond dismissing alopecia areata, dismissing these patients, saying things like, oh, it's only hair, or oh, at least you don't have cancer. We're going to move beyond that to saying, you know, it's awful. I know it's awful. And we're going to get your hair back. It is super important to have a discussion about the potential adverse effects of JAK inhibitors. While we don't yet have a JAK inhibitor FDA approved in alopecia areata or in dermatology in general, we know about the safety profile of JAK inhibitors outside of dermatology. Time will tell, of course, if the adverse event profile in dermatology in otherwise healthy patients with alopecia areata or with atopic dermatitis or other dermatologic conditions is the same as the adverse event profile of patients with rheumatoid arthritis or ulcerative colitis. But again, for now, let's think about what we know about the safety profile. JAK inhibitors have a black box warning for malignancy, serious infections, and blood clots. We don't really understand the blood clot risk. It is small, but appears to be real. The malignancy risk is an important one to discuss with patients, depending on how you look at the data in retrospective, or rather not retrospective, but if you look at database view of malignancy risk, the risk appears to be very small. The infection risk, I think the most important part of this is the herpes virus reactivation, in particular herpes zoster, which seems to occur about twice as often in patients taking JAK inhibitors as in the general population. So in conclusion, advancements in our understanding of alopecia areata pathogenesis have paved the way for targeted treatment of this disease. Again, this isn't that we've seen time and again that a medicine, such as JAK inhibitors, are effective for patients with alopecia areata, and that makes us think that they're useful, but rather we have both science and we have the other side of it, which are patients treated with this class of medicines, that tells us that we're on the right path. We're understanding the immunopathogenesis. In particular, that alopecia areata is mediated by IL-15 and interferon gamma. Both cytokines signal through the JAK-STAT pathway, which then leads to the concept that a small molecule inhibitor called a JAK inhibitor can interrupt disease effectively. Indeed, JAK inhibitors are an emerging therapy for alopecia areata, and presented results of phase 2 clinical trials of JAK inhibitors show tremendous promise. I think that this is an utterly exciting time to be a dermatologist. It's an utterly exciting time to be a dermatologist treating patients with alopecia areata and related conditions. The future for our patients, with this often awful disease is bright. This class of medicines is going to completely reshape the way we think about refractory disease and its treatment. That ends our discussion for today. I hope you found the activity informative and useful to your practice, and I encourage you to access the supplemental materials. Thank you very much for participating.
This activity is accredited by Medical Learning Institute, Incorporated. This activity is developed with our educational partner, PVI, Peerview Institute for Medical Education.